because I had a lot of time on my hands, I was also volunteering at the Emergency Operations Center for the Kenya Red Cross. This is a center that was established after the 0708 post-election violence to link the different disaster response teams in the country. So what we were doing with them was, there was an emergency number which still exists to date, 1199.
What is the most difficult encounter have you had during an evacuation?
I've had several, but what comes top of my list is on an evacuation I did for a pediatric back in 2021, beginning of the year. I was just a few months into the job. So we received a distress call 30 minutes to the end of the shift. Of course, that's a bummer, but you still have to do it. So proceed, traffic was heavy. It was during the construction of the expressway. So you can imagine the Mombasa traffic. But we get to the patient about 35 minutes later. So the history was, this was a 5-year-old boy who had just come from school. The mom had picked them from school. They live on the 4th floor of a building. And then the mom left the kid playing on the balcony. It's a sad story, but it is what it is. So the mom goes to the supermarket to get a few things for dinner. Then, unfortunately, this kid fell from the 4th floor of a high-rise building all the way to the ground. So the neighbors rushed this 5-year-old to an outpatient clinic. The outpatient clinic, unfortunately, was not equipped enough. And the child needed to be intubated because they were not able to protect their airway. They could not breathe on their own. They could not get air into their lungs because they were not able to stay conscious. So we get there, we had an advanced life support ambulance, which we like to call an ICU ambulance. So we had an intubation kit, the laryngoscope and all. So we get our kit and everything to the hospital. We try to intubate. The intubation is unsuccessful at first. The second attempt was unsuccessful. That attempt, lots of things went wrong. And unfortunately, we ended up losing that child, even without evacuating. So that thing, or that incident has really taken a toll on me several times because there's always this question, is there more that we could have done for this child? Is there more that could have been done from the point that the child fell? Because of course, you know that in cases of head, neck, and spinal injuries, movement, even the slightest, is going to make the situation much, much worse.
Very hard for you to have a successful intubation.
Could be.
Wow. And again, you go back and ask yourself, are people trained?
Exactly.
Because they just evacuate.
So that also again helped me to pick up a lot of gaps that we are having in the current emergency care space.
Yes.
And through that experience also, I would say it has shaped me better because it has helped me learn how to become a better provider and also how to educate the public more on what needs to be done and what doesn't need to be done in an emergency.
I feel like at this point now that we are talking about that evacuation, especially at a scene of an accident, can you educate the public? What is the public supposed to do?
Okay. When talking about accidents, an accident which has just happened, say, along the road, it's a motor vehicle crash or a road traffic accident, as we call them. The important bit is to remember to stay safe. Safety is always the priority. If you're able to get the lifesaver triangles, which are ideally supposed to be in every car, use them, place them on both directions to warn the oncoming traffic that there is an incident, they should slow down. If it's not available, you can use branches, leaves. You can even use traffic marshals. You have somebody who has a reflector jacket, could be a boda rider. Let them assist you in flagging down the oncoming vehicles to make the area safe. After that, you also need to ask yourself, is it really necessary to move this person out of the vehicle? Because what happens in most situations, an accident has happened, For most people, if we are not busy recording using our phones, then we'll be busy trying to pull these people out of the vehicle, in which both situations are not really assisting. So we advise you, unless this vehicle is about to catch fire, please don't get this person out.
Please repeat that.
Unless the vehicle is about to catch fire, please don't get this person out. If they can be able to get themselves out, walk away on their own, let them do it. But in most cases, lots of people who are paralyzed after injuries or after road traffic accidents, you find that they are not paralyzed because of the injury, but chances are they are paralyzed because of how they were handled after getting the injury. So sometimes, yes, our intentions are good, but we end up making the situation much, much worse.
So if you don't remove them from the car, who is coming to remove them?
Now that's where we come in. That's where the EMTs and paramedics come in. Our numbers are available everywhere.
The public is unaware of what to do in case of a Narok Maimahi Road. There is a crash. Just to me, that Maasai was grazing cows. We just rushed to try and help you. I think it's the awareness that has not gone deep.
Yep.
And we will not be having enough EMTs. I think there might be enough in Nairobi, but I think counting don't have enough.
What I'd say is that with the EMT field, it's still a bit of tricky discussion. We are still having a lot of legal hurdles which we have to overcome. Actually, as we speak, EMT has just been recognized as a cadre by the KH
So we are 18 cadre.
Yes, so I believe we should be the 18th, if I'm not wrong. It hasn't been there at all.
It's now regulated, it has a license, it's credentialed.
Yes, it should. I know we are still at very early stages. It's communication that I just got yesterday. I've not had time to look at it in details, but we are moving somewhere because for this whole system to work, we need a policy. We need rules which are laid down, and we also need standards which are going to ensure that, number one, from training is being given as it should be, and even the hospital experience, the clinical experience is being gotten as it should be.
I'm asking that with the knowledge of my clinical and the lack of awareness that EMT is a fully medical career that should go to the scene and do what they need to do without saying, oh, what a daktari akuze. See, that's the assumption that EMTs are just evacuators and
we do transportation.
See, everybody knows that, right?
Yes.
It's not me alone.
No, it's not you alone.
So we have to demystify that they have the competency to manage a patient before hospital arrival.
Yes.
Wow. So if somebody wants to be an EMT, what are the qualities of a good EMT person?
Okay, that's a tough one because different qualities make different healthcare providers. And you find that, for example, in my standards, what I would consider a good EMT is someone who is able to do the best that they can for the patient. So number one, a good EMT must be a patient advocate. So that means you must, number one, take your time to explain to this patient what their rights are in your ambulance, that they have a right to refusal of treatment. They have to consent for any procedure to be done, because there are people who just naturally dread or fear getting into an ambulance. Right? But you need to educate them that this is what happens in an ambulance, this is what you're going to do. You being in an ambulance does not mean that you're going to die. Even when you get to the hospitals, it is the responsibility of the EMT to hand over this patient to another healthcare provider. So for example, moved a patient from a road traffic accident along, say, Limuru Road, Mombasa Road, whichever road it is, to an hospital. When they get to that hospital, I'm not just going to abandon them at the casualty area. I have to hand over this patient to the next level of care. If that patient is alone, they are unaccompanied, then I also have to do registration for them. So that is also part of being the patient advocate, because you are doing for this patient what they would not have been able to do on their own.
Wow, we've gone too deep in EMT care and we didn't even finish schooling.
Yes.
We didn't finish going to school, and we are managing patients.
Yes.
So now, you didn't stop learning at
No.
that level.
No, I did not.
Take us to the next step of learning.
All right, so I've completed my EMT. I've done my bit of volunteering at the Emergency Operations Center. I've now started working in the ambulances, and I'm still doing trainings at that point. So this time I now go back to something different. I now venture into basic life support and advanced cardiovascular life support trainings. There's just short courses for medics, nurses, doctors, clinicians, all healthcare providers. So I got into that, did the providers course. I also took an instructor's course for the same under the American Heart Association. We completed the clinical mentorship, and then I decided to now take a step higher, something that was going to take me a bit more time and a bit more resources. So I enrolled for my bachelor's in nursing. That is my bachelor's of science in nursing at AMREF, which is what I'm currently into.
The level at which you've done your anatomy and medicine and pharmacology is not as intense as the way it is done by doctors and nurses, but you've been able to do ACLS. ACLS is Advanced Life Cardiac Support, which is even hard for the nurses. How are you able to do that?
I would say I had a plan. I knew what I wanted to do, and I had no option because I knew that I have the capability to grasp these concepts. I have the capability to connect what I have seen in the field with what I can read in the books. And I'm always very thankful to E+, because through E+, I've really been able to learn a lot about patient care, interact with different cadres of professionals, with the pharmacists, the nurses. So I've always been curious, and that curiosity, I'd say, is what helped me even gain interest in ACLS and realize that this is something that I can be able to do, and this is something that I can be able to understand the concept and not just master it, but pass it on to another person and make them understand it as well.
For sure, because those things are not easy, man.
They are quite difficult.
They're not easy. I'm here confirming, yes, I've done ACLS too.
Yes.
It's not something you just wake up and sit down and do.
True, very, very true. Needs a lot of preparation.
It needs a lot of intense work. So now, you decide to, which is this, you decided to do Bachelor's of Nursing?
No, bachelor's, that was in 2022, last year.
Oh,
Yes.
It just begun.
It just began.
It's a 4-year?
Yes, it's a 4-year program.
Fifth?
Well, the way it's structured, we're having tri-semesters. So that shortens the period a bit. So at the end of the day, let's just talk with 4 years or so.
What made you decide to do nursing?
Now, what made me decide to do nursing, I wanted to move it up a bit from my EMT. So there were 2 career paths that I would have followed. One was paramedicine, whereby I would have done maybe a diploma or a degree. But now you see, the problem with paramedicine is, as I've told you, there's always been a gray area, especially when it comes to the law. Exactly. So that became a problem because at that time, there was only one institution offering the degree program and only 2 institutions offering the diploma program. So it was still a bit shaky. And remember, I'd already taken a gamble in quitting law school. So I was not in the mood to take another gamble. So I just decided to directly go do my degree in nursing.
Wow. How is nursing?
Nursing is good, not a lot of new concepts. And the only difference is that now we are moving from emergency care to a bit of bedside.
Management.
Yes, to city management. And the beauty is, one, you're able to connect. Because, for example, if you talk about anatomy, at EMT level, you are beginning with the body as is. But at nursing level, you are beginning from the cell.
That's why I was asking, how you're able to do ACLS, because from nursing, you begin like a baby.
Yes.
Until you in EMT, you're like crash program.
Exactly.
Okay.
Exactly.
All right.
Yeah, so it's actually been a good experience because I've been able to even now understand some EMT concepts better through nursing.
You've done your brain so much in justice. So where do you see your journey in after nursing?
Really hard to tell. Really hard to tell. We can only make plans. Sometimes they do work out, at other times they do not. But my vision is to teach.
Okay.
I consider myself more of a teacher than a practitioner, yes. So I prefer teaching than practicing, because if I teach, I'm going to reach around, I was just doing a brief analysis. I train about 100 people per week, different categories. But if I was practicing in the ambulance, and maybe just, let's say, 3 patients per day. So in a shift, that's like 10, you're right. So I feel that training is much, much more impactful, because we have a lot of EMTs. For example, if you look at the Kenya Council of Emergency Medical Technicians today, they've trained over 1,000, almost 1,500 emergency medical technicians. Others have gotten into different fields, others are still in the field. And I believe there are a lot of EMTs who can practice. So we decide to leave the practicing to anyone who wants to take the opportunity. But for teaching, I believe that is the main thing I want to do for the long run.
So during your day-to-day work activities, there is a major emergency that you handle that you feel the public has less info, apart from accidents.
Yes.
Which is the other one?
Bleeding.
Bleeding from the wound.
Just bleeding generally.
Okay.
Yeah, because I think the issue with first aid is we all assume we have the correct information.
For sure.
And that's where the problem comes in, because, for example, if somebody is seriously bleeding, you'll find a lot of conflicting opinions. Somebody is suggesting salt, somebody is suggesting
People still
spirit.
do those things.
Yes, it still happens. You'd be surprised as to how many people still put salt on wounds.
Do you guys still put salt on a wound and spirit? Do you still do that?
It
I
happens.
thought it's burns that
It
has
happens.
so many contradicting
Actually,
things.
burns is also another one, because with burns, somebody will tell you of cooking oil,
Urine.
transformer oil, urine, toothpaste, unga.
Yeah.
So you're like, okay, but I don't think there are so many things which could work on just one.
Please leave burns alone. Don't touch any burn, isn't it?
Yeah, just use water. Water works well.
To cool the place,
To stop the burning process, cool the area, then get to hospital.
Let's manage bleeding.
Now with bleeding, just apply pressure. The secret to stopping bleeding is just applying pressure. But using salt doesn't really work. People say it works because, of course, salt is hygroscopic. It absorbs moisture. So it will kind of make you think that the bleeding is stopping. But at the end of the day, clotting has to happen. And for the clotting to happen, you need to apply some pressure.
So people still mismanage bleeding.
A lot.
Wow.
A lot.
I think for more information about William and emergencies, you need to say if we need to bring him back again to the set. But let's just try to know him better on his career. Who is your hero?
That's a tough question. Living or dead?
I don't know. Which one do you choose? I don't know who you will choose.
If I was to choose an hero, it would be somebody very, very unusual. Eh?
Yeah. All of us are usual. You find everybody usual.
Not really. Not really. But somebody that I really not really, maybe I would say look up to, but I borrow a lot from their principles and what they were able to do, is somebody out of the ordinary, out of what you'd expect. Julius Caesar.
Oh.
Yes.
Okay. For sure.
He's actually being interested a lot in the Roman Empire, the Roman mythology, the Greek mythology, and out of all the people who have existed, I think that guy has a lot I can borrow from.
Okay. That's interesting. That's very interesting. If you're not doing EMT, if you're not doing anything in medicine, what could you be doing?
Now, unfortunately, everything I do seems to revolve around medicine and emergency medical care, because
So you still find yourself in medicine and emergency care?
it one way or another, because I'll either be doing a webinar, a free public webinar on maybe how to do or what to do if somebody has encountered near drowning, they were on the verge of drowning, just things like those. My social media is always filled with posts on first aid and safety. That is from LinkedIn to X to all those other platforms. So I would say my life is basically on training and emergency medicine. But for one hobby, when I get bored or tired of reading and writing and studying, I watch Formula One.
Hey. Hey, okay.
Yes. So
Interesting.
Formula One gives me a lot of it actually gives me adrenaline equal to the same that I would experience in an ambulance.
So you thrive in high elevated adrenaline platforms?
Yes, I do. I do.
Wow.
I do.
Okay.
I do.
So if you perform at the optimum when adrenaline is at peak?
Yes.
Wow. That makes me understand why Lou is boring. There is no adrenaline. For sure there isn't. There is pull and fine. If today we give William a chance to head the health docket in this country, where will be your focus?
Okay, my focus, and that's actually a very good question, because it's something that I've always thought about. My focus would be on primary care. We discuss primary care, primary health care on a daily basis. And in specific, something that I would really love to see change is for us to just have a central emergency number.
Yeah.
It beats logic to have Red Cross having their own emergency number, St. John having their own, Ambref having their own, Rescue or Flare having their own.
But that's doable.
It's just complicated. So.
I'm even asking right now, viewers, that's possible. Like, get those CEO board members together, and but it's because everybody's working as an entity. It's a profit-making organization.
Exactly. So if we could get the emergency medical services to be a bit more centralized, then I feel we would be at a much better place, because we would have maybe just have a single number, maybe even a number like 999, because 999, 911, 112.
Does it
Yes,
work?
they do exist and they do work. Yes, they do work. They actually work. But now problem is they go to the police.
Yeah, that's what I thought. With police evacuate, does it have an evacuation emergency?
No, they do not. Now the police will give you another number, which wastes a lot of time.
Allow me show my ignorance, because I think my life has been in hospital care. I've never thought about pre-hospital care management, and I think there is such a huge learning curve to get from the pre-hospitalization. We might even decongest hospitals.
Yes, actually a lot, because we have cases in which people go to hospitals for situations which would just have been sorted out by EMTs and paramedics. We have situations whereby in most hospitals we don't even do triage. In Kenya, it's on a first come, first served basis.
Yeah.
But when you're doing a triaging, you realize that there's somebody who's on the queue at number 2, but they're just having a flu. They just need to go home and hydrate. But there's another person at the back who is having, say, a pulmonary embolism, or even suffering a stroke. But they are just on the line because it's a first come, first served basis. So if you can implement things like triage, if you can be able to get more pre-hospital care providers on board, then I feel there can be a lot of change.
Wow.
Because in situations like, say, cardiac arrest, if somebody is having a sudden cardiac arrest, it is not about how good of an insurance cover you have or how close you stay to an hospital.
No.
It is about what is going to happen in those first few minutes. Before you get to the hospital. So if we can get somebody calling an ambulance, when you call the emergency numbers, you have an emergency medical dispatcher. That person not only dispatches an ambulance to you, but they are also informing the hospital, and they're also giving you pre-arrival instructions. So what can you do as you wait for this ambulance to arrive? Do you need to resuscitate? Do it. This will keep this person alive as the ambulance tries to navigate through the traffic.
That's a huge... Wow. Yes, you've had everybody in the ministry. I hope you've had every service provider, all the members of EMT Council. That's what it's called?
The Kenya Council of
Kenya
Emergency
Council.
Medical Technicians.
Yes, you have had. If we can centralize this care, the police also need emergency care. They don't provide emergency care. And that is a wrap from the health focus this week. And we are so grateful to have had William talk about emergency management. And trust you me, this won't be the last time you're having him here. And in case there's something you want him to address when he comes, comment down below and let's continue learning. See you next week. Have a good week ahead.